Thank you very much, moderator. Let me first of all thank the Association of Community Pharmacists of Nigeria, YESBA Zone, for inviting me to this very important topic. Just like was said earlier, it's very topical. A lot of people are discussing this issue, and I believe we'll have one or two things to take home at the end of the day. I would start by, first of all, looking at the need for pharmacovigilance. It's always important to start from the basis. Why pharmacovigilance? What are the things that we need to do to ensure that we are vigilant on medicines, especially medicines that tend to be overused or used irrationally? Then after that, we will now go to ivermectin, look at the safety profile, what are the arguments for and against its efficacy, and so on and so forth. And then what are the roles of pharmacists, particularly community pharmacists and other healthcare providers in all of these. So the outline is as shown. I hope we can see the slide. Moderator. Moderator, I hope you can see the slides. Okay, let me assume we can see the slides, and I hope we can hear me. So the outline, we have the overview of pharmacovigilance, brief pharmacology of ivermectin, repurposing of ivermectin and the safety concerns, and this is very, very key. And then that led to the concerns about the adverse effects of ivermectin. And then what are the roles of the pharmacists and other healthcare providers? And then conclusion. So an overview, what is pharmacovigilance? Pharmacovigilance is the science and activities relating to the detection, assessment, understanding, and prevention of adverse effects of drugs or any other drug-related problem. Each time I define pharmacovigilance, I normally stress this. It's not only about adverse effects reporting of drugs. It's not only about adverse drug reaction, but rather the entire drug-related problem, which includes overdosing, which includes underdosing, which includes drug-drug interactions, which includes effects from substandard use of medicines, irrational use of medicines. All of these are covered under pharmacovigilance. And there are two basic types of pharmacovigilance. We have the passive pharmacovigilance, also known as spontaneous reporting, and the active pharmacovigilance, that is a hot pursuit. What operates in our system basically is a passive pharmacovigilance, where healthcare providers are required to fill a form when the patient reports an adverse drug reaction to him or her. So he fills the form, probes, asks some questions, and then the form is then placed, reported, and sent to the National Pharmacovigilance Center. Whereas what we should be doing more, especially in a pandemic or in a case where a particular drug is being used irrationally, is active pharmacovigilance. And this is a situation where there is a deliberate effort to actively look out for all adverse events while taking the drug. So we're not only looking out for adverse drug reactions, but all the medical events, so all events that occur while that drug is being taken and properly documented. This is active pharmacovigilance, and this is what we should be doing when it comes to drugs like ivermectin and other kinds of drugs. Now, the aim of pharmacovigilance is basically to collect data, analyze the data, and gain some knowledge about these drugs. So you have to collect data about the drugs through adverse drug reaction reporting. through active surveillance, through post-authorization safety studies, and of course, from the social media. Then you have the knowledge. From there, you create signals. Signals are new information that have not been previously reported. For example, if a person reacts to paracetamol while taking it, and then it's a new information that has not been reported. And that information or that report is repeated in 2, 3, or 4 places. It becomes a signal. So all of these are knowledge that needs to be communicated. And then the regulatory authority will then make use of that knowledge and communicate formally to the healthcare providers to also look out for further signals, further new knowledge regarding that particular medication. And then that can lead to regulatory interventions, increasing the use, proper use, encouraging rational use of the medicines, and discouraging irrational use. Sometimes it may also lead to drastic measures like outright ban of the medication. So when drugs are used rationally from the data that has been collected, this impacts on public health. It maximizes benefits and minimizes the risk. And all of these can also still be collected. This has to be monitored again. How are people using this drug after all of this? Are they changed in their behavior? Are the healthcare providers now prescribing rationally? And then more data is generated, and then the cycle continues. Now, why pharmacovigilance? Again, this is very crucial, especially at this point in time. It's important to distinguish between what we obtain during clinical trials and what actually happens in the real world. You want to look at randomized control studies, and then you want to look at the clinical practice effectiveness of that drug. So a drug may be efficacious, but may not be effective based on the way that drug is being utilized, based on the conditions surrounding the patient himself, comorbidities, and what have you. So in clinical trials, you have dozens to hundreds of patients using the drug, and then rarely thousands. In the real world, potentially millions are exposed to that drug. Then the length of time during clinical trials, sometimes it takes days, sometimes weeks, and a few months. But in the real world, that drug can be used for several years. Then during clinical trials, the population is usually homogeneous. You look at adults, you exclude pregnant women, children, whereas in the real world, everybody is included. Then other treatments are avoided in rigorously controlled clinical trials, whereas in the real world, other medicines are included. The dose is usually fixed. In the real world, it's variable. And of course, during clinical trials, there's a rigorous follow-up, while in the real world, the follow-up is flexible. Patients are less informed and less follow-up. So this makes it very key to really follow up on medicines, to follow up on drugs, not relying only on information gained from clinical trials. Once a drug has been approved based on clinical trial findings, we must go ahead and continue to monitor that drug. And that is the essence of pharmacovigilance. I would implore us to read this paper, a very interesting paper, titled Challenging Times and Opportunities for Pharmacovigilance in Africa during the COVID-19 pandemic. It looks at the panic that usually comes up when people want to use a drug, immune boosters, what have you, and this leads to irrational use. And of course, a lot of information, both right and wrong, is being circulated on social media, and this leads to irrational use, leads to poisoning. For example, the alcohol poisoning from use of and inhaling of substandard sanitizers, or the misuse of chloroquine and poisoning due to chloroquine and hydroxychloroquine, or the hypervitaminosis in an attempt to boost immune system. People go at any length to take several vitamins at mega doses. So these are some of the things that are opportunities for pharmacovigilance. so that we can better inform the public. Now, having said that, we now want to look briefly at the pharmacology of ivermectin. Ivermectin is an antiparasitic drug developed during the 1970s by a Japanese institute called Kitasato and the Merck company. Given its broad spectrum against internal and external parasites that improved animal health in the veterinary field. So it was very effective originally for veterinary use. And then in the early 80s, it was approved for use against river blindness, that is onchocerciasis. And also the use was eventually expanded to include lymphatic filariasis, which was also another debilitating disease caused by filarial worms. And the doses were usually single doses of once in a year for Strongyloides stachoralis, and also onchocerciasis to treat river blindness. And sometimes the doses were increased to up to 400 microgram per kilogram against lymphatic filariasis and scabies. Then 3 or more doses could be used of 200 microgram per kilogram within a month for cases of severe scabies. What is the mechanism of action of ivermectin? It targets the glutamate-gated chlorine channels that are only present in invertebrates, and these are the worms, and therefore it expels the worm through these mechanisms. Mammals do not have such systems, and then the one that is similar to the glutamate-gated chlorine channel is the GABA-gated chlorine channels, and this is only expressed in the brain. And ivermectin, fortunately, cannot cross the central nervous system to get into the brain because of the blood-brain barrier. And of course, there are systems of pumps that pumps out any potential toxin from the system. So this keeps the drug safe for use in man, and then makes it very lethal in the worm. Pharmacokinetics is extensively metabolized in liver and widely distributed in body tissues. The plasma half-life ranges from 16 to 18 hours following oral administration. And some of its metabolites can actually remain in the system for as much as 3 days. Ivermectin is not thought to readily cross the blood-brain barrier, as mentioned earlier, in humans, as it is excluded by a pig-glycoprotein drug pump. And therefore, it has been considered to be free of the potential to cause neurological adverse drug reactions, except in situations of overdose. Now, as a background to this, to the overview of the safety profile, we want to look at the repurposing of ivermectin and the safety concerns. Recently, ivermectin was found to be useful in the treatment of COVID-19. And this is what we call drug repurposing. It was initially discovered and developed for treatment of onchocerciasis and related worms. But eventually along the line, it was found to be useful in vitro and then in vivo for the treatment of COVID-19 disease. Now, it is important for us to look at the evidence-based medicine pyramid. We are in an era of evidence-based medicine. So whatever we want to talk about, whatever we want to conclude upon, must be based on sound evidence. And the highest evidence, as we will see in this pyramid, is the systematic reviews. And this is followed by randomized controlled trials, and then non-randomized controlled trials, and then the observational studies with comparison groups. That is usually these are retrospective studies that you mine the data over time and look at what exactly is the difference between the study groups and the control groups. And then we go down to case reports and case series. So the evidence here is weak and we cannot really take it seriously. Then you have the expert opinion, the anecdotal reports, which we hear from day to day, from time to time, oh, this drug works wonders, and therefore we should use it for treatment of COVID-19. Oh, it cured my parent of COVID-19. So therefore it must be used. So these are just, anecdotal reports that are the lowest level of evidence. Now, there's this alliance called the Frontline COVID-19 Critical Care Alliance. They have done a lot of research, a lot of work, and they came out with a public statement in January, that is just last month, 11/2021, with a one-page summary of the clinical trial evidence for ivermectin in the treatment of COVID-19. And they stated in that one-page summary that ivermectin, an antiparasitic medicine whose discovery won the Nobel Prize in 2015, has proven highly potent antiviral and also anti-inflammatory properties in laboratory studies. Furthermore, they stated that in the past 4 months, numerous controlled clinical trials from multiple centers and countries worldwide are reporting consistent large improvements in COVID-19 patient outcomes. So this means that they actually reviewed different clinical trials and did meta-analysis. They did systematic reviews to come up with that conclusion. Hello, are we together? Can you hear me? Moderator, can you hear me?
Yes, sir, we can hear you, sir.
Aha, thank you very much.
Yes, I can hear you, sir.
Okay, thank you. Now, the FLCCC, that's the Frontline Critical Care COVID-19 Alliance, now came up with some responses, because when they brought out their one-page summary, there were other statements from other well-recognized bodies like the National Institute of Health and Oxford University. The National Institute of Health reviewed the evidence from the FLCCC Alliance and used the evidence to revise the treatment guidelines for ivermectin use in COVID-19. However, they had some reservations and they were not able to adopt COVID-19 as a treatment for ivermectin. Rather, they just made it an optional treatment for priority personnel. So NIH, then FLCC quickly responded to that statement, saying that they countered the arguments of NIH. Part of the arguments of NIH was that the dosage was not uniform, that the sample size was not adequate enough, and many other reasons. So the FLCCC quickly came up with counter arguments and provided sound evidence to counter what NIH is bringing up and encourage NIH to use COVID-19 to use ivermectin as a treatment, given the increased mortality and morbidity on a daily basis in those countries. Then again, the Oxford University has a trial, an ongoing trial called the Oxford Principle Trial, where they randomize patients to treatment and control groups and then using ivermectin. So the treatment is still ongoing, and they insist that they need to do a properly randomized trial before they can give any evidence. And you know, Oxford University is a well-recognized body, and the UK is supporting them and waiting for them. Again, FLCCC Alliance quickly countered the statement from Oxford and told them that how ethical is this? When people are dying every day, why don't you just act on the evidence that we have provided? We have provided systematic reviews. We provided evidence from clinical trials across the world. Why don't you just adopt this regimen rather than waiting for a randomized clinical trial that will take time, given the fact that morbidity and mortality is increasing on a daily basis. So these are in the Western world. And I know that in Nigeria, certain things are also in the making with regards to COVID-19. Now, with regards to the use of ivermectin. Now, Merck statements came up with their own statement. That is the original manufacturers of ivermectin just 2 days ago. And they came up with this statement that there is no scientific basis for a potential therapeutic effect against COVID-19, that is for ivermectin. from preclinical studies. They also said that there is no meaningful evidence for clinical activity or clinical efficacy in patients with COVID-19 disease. And there's also a concerning lack of safety data in the majority of studies. So I would leave you to look at these different statements because they are now contradictory statements concerning the use of ivermectin in the treatment of COVID-19. Now, we are particularly interested in the third statement, that is a concerning lack of safety data in the majority of the studies. And so we decided to look more closely at ivermectin. What is the safety data of safety profile of ivermectin in its approved use and then possibly in the use for drug repurposing? Now, the main requisites for approving a drug to be used at population level is proving efficacy and safety. Once a drug is shown to be efficacious and safe, then it is eventually approved by the National Regulatory Authority. For ivermectin, there is indeed robust evidence of safety when used for the approved indication at the approved doses. There is very limited evidence, however, about the safety of ivermectin at higher doses or more frequent doses, and even less evidence for its safety when used in COVID-19 patients that tend to have pro-inflammatory states. These pro-inflammatory states may increase the penetration of ivermectin into the central nervous system with unknown consequences. Other potential issues include the drug-drug interactions with some antivirals given to the COVID-19 patients. Usually, one part of the standard of care is to give antivirals, such as ritonavir, which may increase the levels of ivermectin and cause toxic reactions. So there's not much that is known from the adverse effects of COVID-19 in trials, particularly in our own environment. Now, from clinical trials and in the treatment of strongyloidiasis, these are the adverse effects that were documented: asthenia, fatigue, abdominal pain, GIT, anorexia, constipation, diarrhea, what have you, nervous system, psychiatric dizziness, somnolence, vertigo, tremor, and the rest. So these were clinical trial findings from the use of ivermectin in treatment of strongyloidiasis. And then for onchocerciasis, we have arthralgia, axillary lymph node enlargement and tenderness, cervical lymph node enlargement and tenderness, inguinal lymph node enlargement and tenderness, and then we have other lymph node enlargement and tenderness. Then pruritus is a significant adverse effect, and then fever, and then frank urticarial rash. And then there are also some ophthalmological side effects that are reversible when the drug is stopped. Now, having said that, these are reports from clinical trials. Now, what are the reports from the real world? And we look at the first one from Nana Tuomdanso, who looked at serious adverse events following treatment with ivermectin for onchocerciasis control. So this was a study that spanned some years and several countries. So it was an observational study looking at what had been reported in the past. And they came up with some adverse drug reactions, but there were a few of those reactions that were serious. And they were, because of the percentage, we can classify them as rare adverse events, but it's important to note them. Now, 85% of these serious adverse events came from Cameroon, which is an African country. Now, 55% of the cases from Cameroon were encephalopathic, that is affecting the CNS, and were reported from the central southern region of the Cameroons. Then another study also looking at the data and mining the data from the Uppsala Monitoring Center, that is the WHO Collaborating Center for International Drug Monitoring. That is the Pharmacovigilance World Center. Rebecca Chandler published this paper, and the title was Serious Neurological Adverse Events After Ivermectin Use. Do they occur beyond the indication of onchocerciasis? She wanted to find out whether the basic reason for the serious neurological adverse event was due to the reactions coming from the worms, the worms that were being killed, and that were there some other possible reasons, such that if you now want to use the drug for another indication, perhaps you will not encounter these serious neurological adverse events. The data source was VG-based, a computerized pharmacovigilance system in which reports describing adverse events are recorded in a structured hierarchical form. Reports are received from national pharmacovigilance centers in 125 countries participating in the WHO program for international drug monitoring. All reports for ivermectin were received into VG-base up to November 2016, and were identified for use in this investigation. So a total of 1,668 reports of serious adverse effects for ivermectin were identified. And most of them were pruritus, about 25%, headache, 13.9%, dizziness, 7%. Now, under the MEDRA system organ classification, which is neurological disorders, there were a total of 426 reports. 156 of these reports were classified as serious according to the ICH guidance. Of the serious reports, 60.9% originated from Africa. 2 patients had a fatal outcome reported, and 1 died of asphyxia 5 days after a dose of ivermectin. Now, what was responsible for all of this? Could it be just the killing of the microfilarial worms? What really happened? Drastic killing of circulatory microfilarial worms could lead to the blockage of blood vessels in the different tissues and organs. When this happens, an inflammatory reaction sets in, activating the fibrin pathway, whereby fibrin clots are deposited in tissues. And this leads to a series of inflammatory release of inflammatory cytokines. And these have been implemented as being part of the pathological signal cascades in brain diseases. So this was the proposed mechanism for the neurological side effects. And this series suggests that serious neurological adverse events observed with the use of ivermectin in treatment of onchocerciasis may not be entirely explained by the concomitant eye-burden loasis infection. So the argument was that the adverse effects could have been due to the onchocerciasis infection and also concomitant infection with loasis. So these two could trigger a series of inflammatory adverse reaction that can affect the brain and allow entry of ivermectin. On the other hand, it was also found that there may be some other possible mechanisms behind these reactions. And these include concomitantly administered drugs, which inhibit the CYP3A4 isoenzyme, and also polymorphisms in the multi-drug resistant gene. So if there are polymorphisms in the multi-drug resistant gene, that could affect the entry of ivermectin into the brain through the blood-brain barrier, because this gene is supposed to pump out the drug and protect it, protect the brain against its toxic effect. So if these genes or the pathway is compromised, then you can have increased concentrations of ivermectin in the brain, and this can lead to serious neurological effects. So in essence, it may not only be due to the concomitant, the worms, but there may be other possibilities like the drug-drug interactions and the deficiency in the multi-drug resistant gene due to polymorphisms. Then again, there are some rare adverse effects of ivermectin. 10 is one of the serious rare adverse effects. 10 is toxic epidermal necrolysis. So this was found in a patient. It was a case report, and the patient experienced 10. And it was found that this patient had actually experienced an adverse reaction in the previous year, and eventually, when was given another dose of ivermectin, then reacted violently. Again, there is the rare adverse effect of Steven-Johnson syndrome, and this is also a case report of the use of ivermectin. So these are case reports that are rare, but it's important to note them, and it's important when we are educating the public that ivermectin is not just a drug that you could just take over the counter without due consultation, due counseling, and due diligence before it is being prescribed. So what are the possible mechanisms of the severe adverse drug reactions from the use of ivermectin? That is the rare cases, HJS and TENS. The result of inherited or acquired deficiency in enzymes required for the detoxification, the detoxification could be a possibility. Also, cutaneous ADLs may result from increased levels of isoforms of cytochrome P450, responsible for obtaining drug metabolites from associated drugs. Again, increased levels of substances serving as possible immunogens or cytotoxic agents may thus result from these metabolic discrepancies. So when you have increased levels of isoforms, and this could lead to metabolites that have different toxic levels or toxic effects, and this may cause some of these severe adverse reactions. There have also been adverse drug interactions when ivermectin is used along with certain drugs. That's been found that it interacts with warfarin, and that in another study there is prolonged prothrombin ratios, in about 148 subjects given ivermectin orally. Again, concomitant administration of some drugs can increase the bioavailability of simultaneously administered ivermectin. So certain drugs may interact with ivermectin, like ketoconazole, loperamide, verapamil, itraconazole, cyclosporin, trifluoperazine, just to mention a few. So these drugs compete for certain transport proteins, and this may reduce or reduce their efficacy, reduce the efficacy of this P glycoprotein, and therefore increase the levels of ivermectin in the plasma. Again, there are certain reports of food-drug interactions, co-ingestion of alcoholic drinks with ivermectin is not recommended, because ivermectin association with GABA receptors and the effect of alcohol in the central nervous system. So there's an additive effect or a synergistic effect when there is an concomitant administration of ivermectin with alcoholic beverages. Then again, orange juice decreases the AUC, the area under the curve, and the Cmax of ivermectin, possibly because fruit juices and constituents are potent inhibitors of certain drug transporters. And the potential drug-drug interactions and drug-food interactions exist for ivermectin, which should be considered during therapeutic use of this drug. So stressing the importance of drug-drug interactions when ivermectin is being utilized. So what is our role as healthcare providers? For the pharmacists, for the community pharmacists, it's very important that we practice pharmaceutical care. And this is hinged on three important points or three important pillars, with the patient as our primary concern. Firstly, responsibility to the patient. Following up on the patient is also your patient. And whatever drug that you are giving to the patient, be it ivermectin or any other prescribed medication, you need to counsel the patient and advise the patient and follow up on that patient. So responsibility to the patient is important. The second pillar is therapeutic relationship with the patient. And the third pillar of pharmaceutical care has to do with documentation. So all of this is very important in following up of the patient. And there must also be post-marketing surveillance. We've educated ourselves on the need for post-marketing surveillance, that whatever we report during clinical trials is not sufficient. We cannot go to sleep and rely on findings from clinical trials. We must continue to monitor this drug even after it has been approved for use in the larger public. And this must be done systematically by both pharmacists and other healthcare providers. So there must be regular and systematic use of the adverse drug reporting forms. And then lastly is education. Educate the public, educate other healthcare providers, and then counseling the patients on the possible side effects, drug interactions, and consequences of irrational use. In conclusion, ivermectin is safe for use based on approved doses for approved indications. However, potential risk to patient safety avails given the irrational use and the poorly regulated healthcare practices in Africa. Therefore, there's a need for pharmacovigilance and strengthening our reporting systems to characterize, communicate, and minimize the risk of from ivermectin. Thank you very much for your attention.
Thank you very much, sir. Thank you so much, Professor Oriagba. That was wonderful. And we're very, very grateful that you're able to, give us all this time. Thank you so much, sir. So I think we'll take our questions now. Please, if you have any questions, kindly post on the chat. So the first question I have here, sir, is that I think somebody posted on the forum. It said something about, the first question was, what is the correct dosage of ivermectin and how long does one take it for? That was the first question, sir. I think we can just take it one by one because they are all very different questions, sir.
Thank you very much for that interesting question. Now, the approved dosage for ivermectin for the treatment of onchocerciasis and also the related worms is basically 200 microgram per kilogram. Okay, and when you translate that to an average 70 kilogram individual, you are looking at 5 to 6 tablets of ivermectin. That is about roughly 15 milligrams. And usually it's a single dose. And at most, it's taken in a single dose monthly for 6 months, depending on the worm infestation. So within a month, you could take one single dose every 6 months. And so therefore, within a year, you're talking about just 2 doses. For other related worm infestation, you could be taken every week for just 1 month. So these are the approved doses, for treatment of worm infestation. Now, for COVID-19, we cannot say whether there's an approved dose. All of these are based on clinical trial, findings, and there's still a lot of studies going on that. Thank you very much.
So we can say that we are left on our own to decide. Is that what we want to take from this meeting, sir? Because I think the healthcare team, I know you said one of the roles of a pharmacist is to educate the doctors, other healthcare professionals. So they come to us now and they're asking us, what would your advice we say, sir?
Thank you very much. Once they come to you asking for ivermectin, you have a very important role to play.
Of COVID. Yes, sir.
For treatment of COVID-19, you are a professional, yes, you are an expert on drug. So you need to first of all sit them down and educate them on the potential health hazards of ivermectin. That is one. 2, ivermectin is supposed to be a prescription drug. And so therefore, they need to get a doctor's prescription before they can use ivermectin. However, because we're in a pandemic and people will always want to go elsewhere, even if you don't give them if you don't prescribe to them, people will go elsewhere. In fact, I'm aware that in some communities in Nigeria, ivermectin is being distributed to the communities, yes, irrespective of the possible adverse effects. So because of that, it's important for you to limit the dosage. You might advise them on the dosage. Okay, use the approved dosage for ailments infection, which is a single dose. You could at least say a single dose once in a week for maximum of 4 weeks. I think that is fairly safe for whatever
Okay.
treatments related to COVID-19. Thank you very much.
Okay, sir. Thank you, sir. So I'll take the next question. It says, can people who are immunosuppressed take ivermectin? If yes, can they take it as a prophylaxis? And what is the prescribed dose? That's the next question. Can people who are immunosuppressed take ivermectin?
Okay. For those that are immunosuppressed, they can't take ivermectin because when you say immunosuppressed, that is the immune system is down, and such people are even more vulnerable to the virus or the worsening effect of the virus. So they are even the ones that may require ivermectin or interventions. But then again, it's important to do due diligence if this drug may be taken. Remember, there are contraindications to the use of ivermectin. For example, people that are asthmatic cannot use ivermectin. People that are sensitive to certain drugs may not be able to use ivermectin. So it's not a blanket prescription. Otherwise, you just worsen the position of that patient.
Okay, sir. Thank you, sir. Another question I have here, I know you have answered part of it, but we really need to conclude. It says, what is the efficacy of using the drug as a preventive measure in COVID-19? You already told us you advised that we can use for treatment, probably like you're treating helminthitis. So, but in a situation where we are using it for preventive, what dose would you recommend?
I would also recommend the same dose because we are now calling it preventive treatment. The person
Yes,
has been
sir.
exposed to
Okay.
COVID-19 most probably, and he's not showing any sign or symptoms. So it's like preventive treatment. So what to do, just follow the same dose, the single dose once a week for 4 weeks. Thank you.
4 weeks. Okay, but we are seeing prescriptions that are saying 12 milligrams, some of them 12 milligram daily, day 1, day 2, day 3, day 4. How do we handle such, considering all you have said now?
Exactly. There are prescriptions. Some say 12 milligram daily, some say 15 milligram daily for 4 days or for 5 days. These studies are not concluded. Of course, there are some clinical trials in other parts of the world that have shown the efficacy of daily dosing. Okay, but from a proper analysis, you'll find out that even these single doses of ivermectin weekly for 4 weeks will do almost the same thing as the daily doses, because eventually the virus will eventually disappear, whether it is treated or not, once the patient has a good immune system. So you have to weigh the risk benefits. What is the risk of adverse effects from COVID-19, from overdose of COVID-19, compared with the risk of ivermectin? So it's like trying to balance it. So it's good to err on the safe side. Once you give ivermectin, there are laboratory studies and even clinical studies that have shown the potency of ivermectin. So it's not until you use it daily over a period of days before you eventually see the effects. You remember hydroxychloroquine, so people felt that you needed to use it all the time, and that led to poisoning, chloroquine poisoning. So we need to be careful. It's better to use it and use it in a moderate fashion. You are likely to achieve the same effect when you use it as recommended. Thank you.
Okay, sir. Sir, any side effects with anyone that has high blood pressure, diabetic blood pressure? You already told us it's a no-no for asthmatic patients. So patients who have high blood pressure, diabetes, what do we advise? Is there any risk?
For high blood pressure, again, there's no evidence for the for not using ivermectin for people that have comorbidities like diabetes or high blood pressure. But again, one needs to be extra careful because those people that are hypertensive will also be using other drugs for to treat their blood pressure. And some of these drugs have the potential to interact with ivermectin, therefore leading to higher doses or higher plasma concentration of ivermectin in the system. So that is where the problem is, and that is where we may need to discourage the use of for such patients that are hypertensive. Thank you.
Okay, so you're advising that we may need to check the drug-drug interaction and advise the patients
exactly.
accurately. Okay, thank you, sir. Another thing that somebody asks is that what is the role of meta-analysis in the review of all the different randomized control stroke clinical trials in support or against the use of ivermectin? What is the role of meta-analysis in the review of all the different trials?
That is a very brilliant question. And I know it's likely to come up sooner than later. Well, you see, meta-analysis, if you look at the evidence-based pyramid, it looks at several clinical trials, several well-conducted randomized clinical trials across the world, and then provides evidence, statistically significant evidence of efficacy and safety of ivermectin, okay, in the treatment of COVID-19 or whatever indication. So it's more or less the gold standard. Having conducted randomized clinical trials, the next thing you want to look at several randomized clinical trials and then look at the statistical significance. So meta-analysis is very key. And if you have a group bringing up findings, positive findings from meta-analysis, then what you should do as a regulatory authority is that is what I would say. So the role of meta-analysis is very, very key. Now, in the Western world, where we have a pandemic that is worsening, the second wave is even worse, and you have people dying in their thousands on a daily basis, and then with evidence from meta-analysis, the role meta-analysis should play when you have positive findings is to adopt the findings and adopt that drug for COVID-19, given the pandemic situation, the emergency situation that they find themselves. So it has a very important role when you are looking at the effects in the efficacy and the safety of ivermectin in COVID-19. Thank you.
Oh, okay, sir. Somebody said here that that in the presentation on the adverse effects, you know, for in the study in Cameroon, that they had a higher percentage of ADR. Is there a genetic predisposition to this?
Okay, that was one of the probabilities that it's possible that there are certain groups of patients in Cameroon that had deficiency in the MDR gene. Okay, that is the multi-drug resistant gene. The role of that gene actually is to protect the brain against entry of the ivermectin into the central nervous system and spinal cord. So for people that have mutations in that gene, what happens is that they are not the gene, the PGP gene, that is the MDR gene, is not able to pump out ivermectin. And so therefore, it is possible that the toxicities, the neurological side effects that we mentioned earlier could be due to a few patients that had deficiencies or polymorphisms in their genes. So it's a possibility, and it was mentioned in that paper. The other paper too mentioned it, and it is a possibility. So it may not only be due to the concomitant loasis infection or the onchocerciasis infection alone leading to the ADRs. There may also be independent effects, you know, people that have mutations in their genetic makeup. Thank you very much.
Okay, sir. Okay, I want to take these two questions together. Somebody said, do we have an idea of how long the immunity will last? You know, you said we could take it prophylactically for just 4 weeks in a month. That's 4 doses in a month. So would that be all? And would it last seeing that we have so many waves. We are on the second wave, we don't know the third wave and all that. And then the second question I'm taking with it is somebody saying that, is it possible to test positive a week after testing negative? He said he was positive about a month ago. He used ivermectine 12 milligrams for 5 days. He felt better afterwards and tested negative. And then almost 3 weeks later, when he had to travel, he was positive again.
Okay, thank you very much. Ivermectin is not an immune booster. We need to get that very clearly. It is not an immune booster. What it does is to eliminate the virus. It prevents the entry of the virus. Okay, so it deactivates the virus and kills the virus. That is the SARS-CoV-2 virus. So when you administer ivermectin, it clears the system of the virus. And if you are exposed to ivermectin subsequently, then the virus comes in again and you could test positive. So it's not only about taking ivermectin and going to sleep. The non-pharmaceutical interventions like social distancing, washing of the hands, you know,
Still
and it's still very, very important. It's not a vaccine, okay? It's just a drug that has a potential, a good potential in reducing the morbidity and mortality from, COVID-19. Thank you. So the same person that had COVID-19 and was tested positive and then negative could also be positive if he was exposed. Thank you.
Exposed again.
Yes.
Okay, sir. Thank you, sir. Okay, somebody said, can one, okay, I think we have answered that. We have answered that. Okay, our own question from the zone is that actually we have a website that has a pharmacovigilance section. And we actually will want to know, how do we go about this? How can we monitor our clients that have taken ivermectin? How can we do a pharmacovigilance study on this? Especially, I think this is a time for community pharmacists can do something. So if we have a place we can post, like on our website, we have a place we can post and things like that, report cases, who you gave the drug to. So we really would like to know how we can go about this in a standard way, such that it becomes, the data we generate from this will become useful.
Okay, thank you very much for that question. I saw on the social media a particular questionnaire on pharmacovigilance, on COVID-19 in general. And I must commend the people that are doing that. That's a fantastic way to go about it. You should start with a questionnaire, a baseline study. What are the perception of the public on the different treatments or remedies and the vaccines for COVID-19? We need to know, what do people think about this? How do they use it? What are their feelings? Which ones do they use most often? Which one would they prefer to use? Are they into traditional remedies? So that baseline study is very key, and you can do it even on social media. So that's the first thing. Then secondly, we the medicine safety app. It was launched late last year and launched by the National Regulatory Authority, NAFDAC. And you can easily download this app from the Play Store. You'll find it there. So that app is an app for you to actually document adverse drug reactions, okay, from the use of any drug whatsoever, so long as you describe the adverse drug reaction, the name of the drug, when it started, when it stopped, all of this, just like filling a yellow form, okay? And then once you fill in that app and submit, it goes straight to the National Pharmacovigilance Center immediately. So that's a good way to go about it. But at the same time, it would be nice for the zone to have their own documentation too. So apart from the app, you could also have your own app or a system on your website whereby you've created the fields, just like the yellow form, and it's really not difficult. If you have an IT service.
Yes, sir.
Once they encounter an ADR or a patient comes to them, they have to do due diligence. Now, this is very, very key. when a patient comes to you to report symptoms or he wants to use a particular medication in treatment of COVID-19, because this time around you are looking at COVID-19 and then the various remedies. So you need to take the particulars of that patient. You have to do a medical history. You have to do a physical examination for you to be able to follow up. So when you're following up on that patient, you will be able to appreciate, okay, these are the possible predisposing factors for the occurrence of these ADRs for this patient or for this group of patients. So that can be done. It's just like filling the yellow form. But before you do that, you must have taken your data. For each patient that comes to you as a community pharmacist, take proper data. Even if you are recommending the drug to the patient, take proper data of that patient, document very well. Whatever advice you give to that patient, document, and then follow up on that patient. You're more likely to get more information on mild, on moderate, on severe adverse reaction than if you don't follow up. If you don't follow up on a patient and the patient experiences an adverse reaction, you may not know. So we all have to do the active pharmacovigilance, the one that has to do with hot pursuit to really get meaningful information. If we rely on the passive pharmacovigilance, we may not be able to do much. So, and the active pharmacovigilance is the same way, but you are now trying to sensitize the patient. It's possible you may experience an adverse drug reaction. So you all have a uniform time to call on the patient, maybe after 3 days and after 7 days, so that at that particular point in time, if there are no adverse drug reaction, you document it. No adverse drug. If there is no adverse event, because this time what you are following will be adverse events, not adverse drug reaction, as I explained earlier. So you can do it in a systematic manner and you can get very interesting results. And this is the time to really go about it. Thank you very much.